questions on MS. You will have 4 questions on AKI, roughly 2 questions on CPP. You guys will have 3 questions on traumatic brain injury. You will have 5 questions on Parkinson's, so I hope you listen to Dr. Chavez's lecture. You will have 5 questions on seizures. You will have 5 questions on spinal cord injury, neurogenic shock. You will have 5 questions on stroke. You will have at least 7 questions on thrombocytopenia, which include HIT and DIC. And that includes like what's entailed in those things. Like HIT is going to have heparin questions as well. Okay. You'll have 3 questions on hospital acquired infection, on prevention and treatment, and you will have 3 questions on Guillain-Barré syndrome. Okay, so that's essentially the breakdown of the exam. I can say that this exam is not going to be, I guess, as easy as the first exam. A majority of this exam is pretty much NCLEX questions. So I pulled exam questions off of the NCLEX bank, and some of the questions are reworded in a way where it reflects the material we covered. I went through every single question, and I don't think there is a question here that we did not go over. Okay. I feel like if you stick to the study guide, which Dr. Chavez will publish when he lands after his conference, unfortunately, because I'm borrowing his Zoom account, I can't share my screen since he was sharing his screen. And I have the study guide. So he will publish it later on tonight, but we will kind of go over it. And you guys can ask questions as we go through it. Because we've already lectured on these topics, I'm going to go over what you guys need to know. And if you guys have questions in regards to those topics, this is the time to ask. Okay? I know last time we went over the entire study guide and then we covered all of the material in the study guide. But based off of our assessment on how you guys performed on the test, you guys are doing fairly well on the knowledge piece. I think a lot of you guys lost points on reading the question. And that's what we're finding. So some tips is kind of read the question slowly and always ask yourself, what is it that we're asking? Okay? Does anyone have questions so far with like the exam before I get into the material? Now's the time to ask.
Yeah, I have 2 quick questions. The first one is, last week we had talked about opening practice EAQs through Evolve. Is that still something that could be done so we can practice some of these specific questions?
So that is something that Dr. Chavez, so just so you guys understand, I do a lot of the lecture portion and I do the exams. And Dr. Chavez usually manages all the logistics, your grades, your assignments, the posting of like, he handles that material. So that question will have to be answered once I get in touch with him once he's off the plane. Because I don't know I don't have access to Evolve. He does.
Mm-hmm. Okay.
Yeah.
I'll send him an email. And then
Yeah.
my other question too is, so we just covered a lot of meds. Are we gonna get the generic and the brand names for those meds, or will it just be one or the other?
So in regards to medications, you guys should be fairly familiar with kind of group. Like, for example, I don't expect you to know Solumedrol is what we use. You know what I mean? I just expect you to know that Solumedrol is a corticosteroid, and corticosteroids are used to treat certain diseases. Does that make sense?
Yeah. Okay, thank you.
Like, I do expect you to know, like, very familiar drugs that have been kind of drilled throughout nursing school. Like, I expect you to know what loop diuretics are and which loop diuretics are available. You know, there's only really two that they drill in your head during nursing school, and that's spironolactone and Lasix. And they're just counterpart based on electrolyte wasting, right? So those kinds of things. I expect you to know what gabapentin is used for.
Okay, thank you.
Is that fair?
Yeah, I just wasn't sure because, like, for psych, there's so many specific meds, and she really wanted us to focus on one or the other, and she would provide both. So I wasn't sure if covering the meds we did today, if we would need to know both.
Yeah. On the exam, if a medication is brought up, you will have generic and you will have brand, but for me, it's more important that you guys know what you're treating the disorder with. Like, there will always be like a plethora of options for diuretics or for corticosteroids, but just the fact that you know that the disease process is treated with a loop diuretic or the disease process is treated with a corticosteroid, that's enough.
Okay, awesome. Thanks.
Yeah, you guys aren't pharmacists, you guys are nurses. And once you go into practice, you'll have more than enough resources where you can look up a medication and safely practice. Like, we are not pharmacists, we don't do recommendations. We kind of learned through our experience. Okay? Can we go over each question? What do you mean by that, Juan? I can't go over each question of the test. That's like giving you guys all the answers. What I am going to go over are the topics that will be covered, if that's what you mean.
Oh yeah, like for the topics that we're gonna go over, I just meant like something more specific because there's like 700 slides. Like I don't know if I can remember everything. Just to narrow it down a little bit.
You won't need to know 700 slides. Like, trust me when I say the study guide is pretty specific. It's like, if you can answer the study guide expectation in just a few words, you're gonna do fine in the test. I promise.
Okay, thank you.
We're not test heavy. I think you guys have like realized this about us now. Like, we're not test heavy. But I do want you guys to get practice on seeing NCLEX style questions and answering that way. Because I will be honest with you, a majority of you guys used like or responded in questions on exam 1 without seeing the accept part or the highest priority or select the best response, right? So a lot of you guys lost points just on, not that you were wrong in your response, but there was a more right response. Like there's a better answer. You guys chose the right answer, but there was a best answer. And during the NCLEX, you will have lots of those questions. And so I mean, Dr. Chavez and I both agree that testing you the way you guys would be tested in the boards would probably be to your advantage. But the material itself should be covered, and if you participated in class, if you do the study guide, you should perform fairly well. Okay? Any other questions? Nope. Okay. Okay. So, let me just pull this up. Alrighty. So I'm going to read directly from and yes, medications will be there. Okay. So we'll start with some of the things we've covered already. MS, you will need to know classic signs of MS. You don't need to know everything. You just need to know classic signs of MS. As in losing voluntary control, or the fact that early on in MS you'll experience nerve conditions or nerve symptoms due to the demyelination, things like that, like very characteristic MS presentation. You'll also need to know how some of these symptoms are treated. Like, I'll give you an example. If you have neuropathic pain, what would you treat it with?
Caffeinic gabapentin?
Maybe. That could be one thing. Lyrica, also another, right? I just need you guys to know that you can kind of like see larger picture stuff. There's no cure for MS, so MS is entirely focused on symptom management and delaying the disease progression. Okay. Let's just double check that I'm not lying to you guys. Yeah. Let me see if I can share this with you guys. Can you guys see my screen?
No.
Okay. Sorry, guys. I tried. But yeah, so primarily focus on that. So we just discussed Guillain-Barré. For Guillain-Barré, I want you guys to focus primarily on nursing assessment, which we just went over. If you can remember everything I said, that short period of time, you'll be able to answer those questions. So essentially, you want to focus on what we monitor, what we monitor, what we treat, and what we monitor and what we treat, how we treat it, and don't forget that the disease process is ascending paralysis. Okay?
Which neurological disorder was descending process in contrast to that? I feel like there was
Neurological
one.
disorder that's descending,
Yeah.
that's usually every other neurological, it's not a neurological disease, but Parkinson's is descending, and any spinal cord injury is downwards from the point of injury.
Okay.
Yeah. And that's why Guillain-Barre has respiratory compromise, and that's usually what we're like primarily focused on. Okay. Also, just keep in mind how Guillain-Barre is acquired, because as you know, with any viral infections or bacterial infections, you would know how to assess for infections in general. Okay. Parkinson's disease. This is going to be, like I mentioned, several questions on Parkinson's disease. So, Parkinson's disease, you should know the primary symptoms. And Dr. Chavez went over it multiple times. On top of knowing the primary symptoms of Parkinson's, you should know what to expect on assessment for a Parkinson's patient. And since, as you know, Parkinson's also does not have a cure, we are focused on optimization. Okay, when I mean optimization, he talked about occupational therapy, he talked about activities of daily living. He also talked about safety and risk factors on Parkinson's. I know it was a rough lecture today, because when we have Zoom, we're kind of crippled by using slides. So if you guys have any questions on Parkinson's, now is usually the time to ask it. Since I know he had to rush off because he's on a flight. But yes, so you would have to know the cardinal signs and symptoms of Parkinson's. You should know our interventions and our assessment. Like when we see a patient with Parkinson's, how are we going to assess that this patient has Parkinson's? What are the 4 cardinal signs of Parkinson's? What do we do to intervene for Parkinson's? What's our risk factors for Parkinson's? Can anyone tell me risk factors for Parkinson's?
Is it dopamine deficiency or dopamine kind of related?
It is dopamine related. It is a dopamine deficiency. So essentially, Parkinson's is where your cells, your neurons, stop producing adequate amounts of dopamine to produce a voluntary movement. As the disease becomes more degenerative, you lose voluntary function even more so. But with knowing that, what are your safety precautions? Those are the things you have to ask yourselves. What do we know about Parkinson's? What are the things that we know happen with Parkinson's? Okay. You guys okay with that? Yes?
Are we talking about like a fall precaution because patient's gait is kind of unstable?
Yeah, that's one. Right? That's one. You have unstable gait. You have instability of posture. So fall risk, fall assessment. That's good. But things like that. What would you watch out for on a patient with Parkinson's? Okay. So next, seizures. There will be several questions on seizures. One, you have to recognize what a seizure looks like. Okay, seizure recognition is big. And two, your priority interventions when it comes to a patient having seizures. Okay, so one, recognize a seizure, and two, what is your priority intervention when a patient is having seizure? And these are all safety questions, right? Because a lot of your NCLEX questions will be based on how well you practice safely. Okay, safety is a big piece.
For the what recognize what a seizure looks like, does that also mean distinguishing between the different types of seizures?
Yes. That also means post seizure, what will the patient look like? What will you do to support that patient? And if you were listening to the seizure lecture, there is one overarching theme when it comes to seizures. Okay? Can anyone tell me that? Yes? No?
Protect the airway?
Yes, Daria, very good. Protect the airway. And there's a maneuver that he discussed in almost all seizures where we protect the airway in a specific fashion. Okay? So that is your priority action when it comes to seizures. And when we protect our airway, right, there are specific things we do to protect airway, depending on where the patient has the seizure and how the seizure is progressing. Okay? So you guys will have scenarios, and you, based on what the patient is doing, you have to recognize that the question is involving a patient seizing. And it can ask you situational stuff. The patient could be sitting in a chair and the patient has signs and symptoms of a seizure. And then it'll ask you, what is your priority intervention? Or what is the priority, like what is the action that the nurse is expected to do first? Okay? There are questions that will ask you to do first, second, third, or progression. Okay?
Would we always protect the airway first before doing other things? Or like, I know it's also moving unsafe items or making sure like the patient isn't like on a chair, bringing them down to the floor.
So essentially, like, you're protecting the patient from injury, right? But when the patient is seizing, in the act of seizing, right, you're technically shouldn't do anything to the patient except for one thing. And that should be the primary thing you do. before you start moving things, right? So you know, in the hospital, I don't know if they've discussed this with you, but like seizure precautions. Can anyone tell me what seizure precautions are?
Like the pads on the rails.
What else?
Suction, like having a suction tubing.
Yeah. Okay, good. So having suction, having bed rails up, these are all injury prevention, right? But when we protect the airway, why is the airway compromised during the time a patient is seizing?
Because of aspiration.
Exactly, because of aspiration, right? And sometimes they occlude their airway also because of the tongue, right? So when we do our assessments as nurses, right, are we going to protect physical injury before we protect the airway? No, right? Absolutely not. Because it's pointless to protect your patient from injury if your patient can't breathe. Your patient will die first due to an unprotected airway versus them injuring themselves. So in seizures, when we think safety, we should always think recognizing that the patient's in seizure, right? Because aside from active convulsant seizures, we also have silent seizures, right? We should also know manifestation of pre-seizures, like auras. Okay.
You said you wouldn't like touch the patient if they're actually seizing, except for doing one thing. Would that be like turning them to the side, or is that to protect the airway? Or are they kind of like the same?
That's the same thing. You turn the patient to the side because it stops anything from going back. You pull to the left. And then your mouth, mostly, because it's not like you clench or you purse your lips during a seizure. You can clench your teeth, but not really purse your lips. Most of the times, if you've ever seen an active seizure, you see foaming at the mouth or you see drool if you turn the patient to the side. Okay?
Do you turn the patient's entire body to the side or only the head?
Did you say only the head?
Only the head to the side, yes.
No, you turn. If you've ever seen someone convulse, or if you see someone in seize, a lot of the times they could be rigid, stiff. So if you were to turn a patient, like forcefully turn a patient's head, you can injure them. So you turn the entire body.
Got it.
Okay. Good question. Okay. So that's some safety pieces, but you should also know other just preemptive things that can instigate seizures, right? What are some things that instigate seizures?
Like flashing lights, temperature, fever.
Okay. Other things. Yes. Sorry, Anna. Electrolyte imbalances. Those are big. What other things? Acidotic states. That's right, Erin. Anyone else? So don't forget that metabolic processes. Okay? So knowing what instigates a seizure, knowing what to do during a seizure, and the post intervention. What do we treat with what do we treat seizures with? You don't need to know the drug. General's good. Anticonvulsants, exactly.
Capra?
Keppra more specifically, yes. Okay? So pretty simple stuff, right? This is knowledge pieces. But in the test, it's not a matter of knowing it, it's a matter of applying it to the question. One, recognizing that the question is asking seizure. Sometimes it'll say it exactly there, but sometimes there'll be a scenario where you have to recognize that the patient is seizing. Okay? Any other questions? So those are things we all like kind of covered today. Seizures, MS, Parkinson's, and Guillain-Barré, okay? The other things that will be tested on is renal function. We went over AKI. We went over things that may cause AKI. We went over how we recognize when a patient is AKI and some of the things we do or we expect to do when a patient is approaching AKI or is in stage 1 AKI. Okay? So it's pretty simple. If you were there during the lecture, it was pretty short and sweet. Know what causes AKI. There's pre-renal, intrarenal, and post-renal. But most AKI is caused by pre-renal AKI. And pre-renal AKI is usually due to perfusion. Okay? There are other things that we discussed that can cause AKI. So just know what causes AKI. 2, how do we know that the patient's in AKI? How do we recognize that the patient's in AKI? There are two gold standard ways of monitoring a patient's kidney status.
Is it
Okay.
GFR?
Sorry?
Is it GFR?
Not GFR. But you use GFR, but yes, Armand, correct. Low urine output. You have to recognize what low urine output is. Sorry, one more time?
I was saying, and is the second one creatinine levels?
Creatinine, yes, correct. Creatinine levels and low urine output, okay? And then we have to know what is appropriate for intervention when a patient is in AKI. And we discussed interventions for AKI. So know what causes AKI, recognize how the patient is diagnosed to be in AKI, and third piece is what do we do? Okay, what causes AKI, recognizing the patient is in AKI, and that also means that I can present you with a clinical scenario, and you have to recognize that the patient is an AKI or approaching AKI. And what would you do as an intervention to either one, prevent AKI or treat stage 1 AKI to reverse it? Okay. Any questions on the renal stuff? With renal, I also want you guys to recognize when I mean things that cause renal dysfunction, take into consideration other things outside of perfusion. What are other things outside of perfusion?
Nephrotoxic drugs.
Nephrotoxic drugs. What other things? Think diagnostics.
Diabetes.
Diagnostics. More specifically, let's think CT scanner.
Contrast.
Contrast. Contrast is big on throwing patients into AKI, okay? So in those cases for some big overarching nephrotoxic drugs, something that's been kind of drilled in your head since day one in nursing school, or at least I hope it was. Okay, and with these nephrotoxic drugs and things like contrast, what do we do for our patients in order to treat stage 1 AKI or to prevent AKI? Sometimes we even have a plan for patients who are already renally compromised, right? Okay. So any questions on the renal portion?
Do you mean like how we would treat or prevent AKI if we knew we had to give like nephrotoxic drugs for contrast?
Yes.
Okay.
Okay. Okay. So early on, Professor Erickson, Mike Erickson, he did a lot of the lecture on ICP. Okay. So with ICP, you want to know what are the signs and symptoms of a patient who has increased ICP. Okay. With ICP comes CPP, right? So for some of you guys who didn't make the lecture on CPP, make sure you educate yourself on what CPP is and how you determine CPP. Okay? In regards to ICP, you're going to want to know, like I said, signs and symptoms of ICP, emphasis on early and late signs. Know your early and late signs. Okay? You also want to know what affects ICP. Yes, Erin, you will. You don't need a calculator for CPP. I promise.
Will this exam have select all that apply?
Yes, this exam will have select all that apply. Other things you need to know, you also need to understand how the body or how the head, the brain, compensates for ICP, right? There are 3 components that Professor Erickson discussed with you all. Let me make sure. So know those 3 components and how they work with each other to compensate. Also know some clinical signs of a patient in increased ICP. Know your normal values of CPP and ICP.
When you say clinical signs, is that different from signs and symptoms?
So there are signs and symptoms in regards to progression. Like there are very early signs. There's an early sign followed by a secondary sign followed by a late sign, right? When you are in increased ICP, right? So let me rephrase it. Once a patient has an injury, right? If the injury happens, you have an early sign, followed by a secondary sign, followed by a late sign. And once you're already in increased ICP, there are clinical manifestations that happen thereafter, right? So no ICP as it is progressing, and no ICP when it is in late stage and ICP is already high.
Okay.
There's a clinical manifestation that we discussed in class. It's also covered in your book, but in class, there was a key emphasis on this clinical manifestation. Know that. And Professor Erickson also talked about a compensatory mechanism on 3 parts that work with each other. And like I said, know what affects ICP. We talked about certain pressures that affect other pressures in the body, so to speak. Okay? Anything on ICP? Okay. There is also stroke assessment. Okay, this is going to be kind of a big one because it has a good chunk of questions on stroke management, right? We want to know what's our risk factors for stroke, what recognition of a stroke looks like. We also want to determine location of the stroke. And there's usually 2 types of strokes. Okay? And when do you guys understand what I mean by location of a stroke?
No, like how in depth do we need to know how to locate a stroke?
Left side versus right side.
Okay, so they would have like contralateral indications?
Only?
I don't know.
Okay, so you gotta know that.
So we just have to know, well, because I think I remember them saying something like there are certain, if you have like a right-sided stroke, there are certain symptoms on your left and then certain on your like right side as well. So is that what you're referring to? Okay.
Yes. No, if you have a right-sided stroke, what does that look like? I will tell you one thing, that when you say contralateral, that's only partially correct. But like I said, this review is just for you guys to know what material is being covered. I don't exactly want to give you guys all of the answers. So that wouldn't be fair for everyone who's not here. Okay, but risk factors, how we treat strokes, right? There's 2 types of strokes, how we treat them. There is a specific type of treatment for strokes, and know the parameters to when you can treat and when you cannot. Okay, so know right-sided versus left side, what your risk factors are for stroke, and the primary ways we treat stroke. There's only 2 types of strokes, really. There are different types of strokes there under, but primarily two. We categorize them as two. Okay. Anything on strokes that you guys want to ask?
If we know the NIH stroke assessment,
You do not need to know NIH assessment. You just need to know how to recognize a stroke. Let me ask you guys this. What's your when you recognize a stroke, what is the primary thing that you should do? Anybody?
Or rapid response team?
If you're in ICU, which we're in ICU, right? This is an advanced Medsurg, you are rapid response.
Complete like a neuro assessment?
Sure.
Or get a
assessment.
CT?
CT.
Get a
with their-
CT.
Exactly, Erin. That's great. Determine when it happened, when their last period of normalcy was, because that is the first thing any physician will ask you. What time was their last known well? Okay? If you know that, you're going to do great. Okay? That one was a gimme. Anyone else have any questions before we move on? It's pretty straightforward. Know your risk factors for stroke. Know how to assess for the stroke, right-sided versus left-sided, and your primary treatment therapies for the two types of stroke. Okay. So we've only got roughly 45 minutes, and I want to get through most of this. You guys will have the study guide, and I promise you, if you do the study guide, you should be well prepared for the test. Let's put it this way. The study guide was created after the test was created. So the study guide was based off of the questions that you'll be seeing in the test. So if you could do the study guide, you guys will be perfectly fine. Okay? I can guarantee you that. Okay, so the other piece that we want to take a look at is TBIs, traumatic brain injuries. How we manage a patient in trauma. Okay? What our priorities are for a patient in trauma. And our spinal cord injuries. We did an activity for those of you who attended class that day on spinal cord injuries. So know what we are looking for if a patient has a cervical spine injury. Know what it looks like when a patient is in neurogenic shock. What are our interventions for a patient whose spinal cord injury is high enough that it affects other things, like elimination. Okay? What is our priority when we first encounter these patients? What's our priority whenever we encounter patients who are traumatic spinal cord patients?
Hold C-spine?
Is it holding C-spine and that's it?
Maintaining airway.
Yes, maintaining airway. okay? Everybody kind of forgets about airway sometimes when we do spinal cord injury, because very often the trauma in us like reflexively wants to stabilize our patient's motion, right? But always remember, GCS 8, we have to intubate. If they can't maintain mentation, and if our patient is not conscious, airway should always be our primary concern. Okay? Don't forget that. It will serve you well. Okay? So know what we are looking for spinal cord injuries and how we support that, right? For example, if you recognize a patient is in neurogenic shock, what should be your primary support? Anybody? You're in a shock state.
Are we gonna intubate the patient?
We could.
Bradycardia and hypotension.
Yeah. Maintain
Perfusion.
perfusion. Exactly. Maintain perfusion. Okay? And that should guide your care in anyone who is experiencing traumatic spinal cord injuries. You want to maintain perfusion. That's why we have CPP. That's why we have allotted higher blood pressure when these patients are injured in that manner. Because remember, with everything and anything we do, perfusion is always the name of the game. Okay? If we can't get perfusion, everything else doesn't matter. Okay? So just remember where the injury happens and what that affects. And how will we manage? That means recognizing if the patient has a neurogenic bladder, recognizing what vital signs will dictate what looks like a neurogenic shock. Okay? And what do we do for that? So did we go over meningitis and encephalitis? If we didn't, meningitis and encephalitis, we just know what the clinical picture looks like and how we treat and diagnose it. There's literally like 4 questions on meningitis and encephalitis. And with both of those diagnoses, ending in itis, you can kind of figure out which way to go. Okay. Spinal cord injury, neurogenic shock, stroke. Okay. So thrombocytopenia. Okay. Know what thrombocytopenia looks like. You guys had thrombocytopenia over all your courses in nursing school, right? So you guys should be able to see what thrombocytopenia looks like. For HIT, okay, recognize how HIT looks like. And what would you do if a patient was diagnosed with HIT? Hint, hint, know what your reversal agents are.
Are we gonna have to know about the tag and the quantra and
No.
stuff?
The TEG and the Quantra, we taught you guys on TEG and Quantra because of the fact that this is an ICU class. And most ICUs, when a patient is in advanced stages of HIT or DIC, like it's an additional data point to help guide our treatment. But if you guys plan on going to other disciplines outside of the ICU, the likelihood that you see a quantra or the likelihood that you see a TEG, slim to none. I don't even think TEG or quantra is in your NCLEX. But we just want to introduce you to TEG and quantra so you know the values it kind of gives you to help dictate how you intervene for these disease processes. But no, you will not need to know what a quantra is. You will not need to know what a TEG is. But you will need to know how to recognize HIT. What lab value do you think we look at?
PT.
What is it?
PT platelet.
PT platelet, sure, but more specific. Think heparin. HIT is heparinase, right? Think heparin.
Maybe D-dimer.
Not D-dimer. D-dimer is not for HIT. INR PTT is closer, but it's APTT for heparin. Okay, so I might give you an APTT value and tell you a patient is on heparin, and you have to recognize what are the signs and symptoms that determine this patient has HIT. Okay. Same thing with DIC, right? We covered DIC. I covered DIC. And I specifically emphasized how we confirm that a patient is in DIC. Know that. For those of you guys who didn't attend that class, find out what determines DIC. And when I mean by what determines DIC, I mean, what does your assessment look like? What are the lab values we're looking for in DIC? Okay. It's pretty straightforward.
Do we need to know the difference between like HIT type 1 and type 2?
No. Just know what you need to do when you find a patient in HIT. What does it look like? What does it look like when a patient is in HIT? What will we see in our labs? There are primarily two things we can see in our labs. And what are our physical signs of thrombocytopenia? Okay. Let me see. For the most part, that's really it. And then hospital-acquired infections, these pieces are on CLABSI prevention, VAT prevention. We discussed this in class. Recognizing surgical site infection, and we did that exercise on differentiating what we do when a patient is looking like they're developing a hospital-acquired infection. So one, know what your hospital-acquired infections are, and two, we're mostly focused on prevention. I will tell you guys though, there might be a bonus question for those of you who attended that class on just an extra credit question. Just a bonus question. Aside from that, that pretty much covers your test. So it's mostly meningitis, MS, AKI, encephalitis, ICP, CPP, traumatic brain injury, spinal cord injury, Parkinson's, seizure, stroke, thrombocytopenia, hospital-acquired infections, and Guillain-Barré syndrome. And that's your test. You guys have half an hour to feel free to ask me any questions. Aside from that, your study guide will be uploaded either tonight when Professor Chavez lands or tomorrow morning. And I promise you, if you stick to the study guide, you should do well. If you guys have any questions on any of the topics that will be discussed, now's the time to ask. You guys have a spring break next week, right?
Yeah.
Okay. So in the time that you guys are studying or not studying and procrastinating later, and you guys come up with questions, just shoot them over to Dr. Chavez. Okay? If you guys have no questions, you guys are free to go.